Assalamu alaikum, everyone. Apologies for the delay in starting today's webinar. We were experiencing some technical difficulties, which have been sorted now, thankfully, to our IT. So today we are going to be starting our webinar. And I would start off by welcoming you all and thank you for your patience for everyone who had joined us at 8 p.m. and we're waiting. So without further ado, I would like to welcome Dr. Kalbe Abbas, who is the Assistant Professor and Director of Pediatric Critical Care Services, Director Pediatric Critical Care Medicine Fellowship Program at the Pediatrics and Child Health, Aga Khan University, Karachi. Apart from his contribution to pediatric critical care medicine, Dr. Abbas is an accomplished researcher with more than 67 publications as a co-author. His research interests lie in predictive analytics in pediatric ICU and its role in low resource settings, quality improvement in pediatric critical care, respiratory care in low resource settings with artificial intelligence applications, and pediatric ICU capacity building. Today, he will be talking on the topic, the status of pediatric critical care in Pakistan and increasing patient involvement in the pediatric ICU. Welcome, Dr. Abbas.
So thank you very much, Dr. Sama and PCHF team for this kind introduction and for providing me this opportunity to talk on the current state of pediatric cardiac critical care in Pakistan, which is, I think, one of the major focus for the congenital heart disease patient care in Pakistan. And I will also touch upon that how parents or families can partner with the ICU teams to develop and make this experience smooth. So if you can just go on to the slideshow. So pediatric critical care. So what we will be discussing in next 20 minutes or so is to discuss that why critical care is an integral part of the congenital heart disease management, because congenital heart disease, unlike any other disease, is a very complex disease, and these complexities start right from the birth of these patients, and we will be discussing what the current status of pediatric cardiac critical care is in Pakistan, what are some of the challenges, and I'll propose some of the solutions to overcome these, and then I'll be discussing parental experience and how we can partner with parents to make the ICU experience better. So, why? First question is that why do we need ICU? Why do we need critical care for congenital heart disease? So, congenital heart disease is one of those specialities which, in fact, led to the development of pediatric critical care as a specialty. So, this is one of those diseases that require specialized care in the post-operative period as well as in the pre-operative period. And so one of the component that why pediatric critical care as a specialty developed in the world, in the West, as well as in the Pakistan, is because there was a need to provide this specific care to the congenital heart disease patients. And this care is needed right at the time of birth when a child is born with congenital heart disease, because they are sometimes very critically ill and they need to be cared for in a very intensive environment. Then throughout the life course of congenital heart disease, they undergo different interventions, and almost all of those interventions, including all surgeries, require post-operative care in the ICU. And another important thing to remember is that time spent in the cardiac ICU has a long-term impact. It definitely has a short-term impact, but this also impacts the growth, development, the IQ, and multiple other factors of the life of patients with congenital heart disease. And we cannot imagine a program of congenital heart disease without a dedicated ICU, and we cannot imagine a dedicated ICU without a dedicated team and in infrastructure. So keeping this in mind, the need, If we see the current status of congenital heart disease and overall statistics, we can see that Pakistan has a population of almost 225 million. And it is a rough estimate is that we get around 50,000 new patients every single year born with congenital heart disease. And these cases keep on adding up every single year. Pakistan has one of the worst infant and under five mortality per thousand births as compared to other countries which have a similar socio-economic profile like India, Iran, Ghana, Indonesia, etc. And if we see the contribution of all these diseases in the under five mortality, so we see that congenital anomalies and congenital heart disease is one of the major congenital anomaly. So this is one of the causes and risks for this high mortality, which you can see that Pakistan tops this list among the five countries with similar socio-economic profile, and Pakistan tops this. And this is one of the reason that we don't have developed the infrastructure to manage congenital heart disease in our part of the world. And this is where PCHF will have a huge role to play, and we will keep on discussing this as we move on in this talk. So if we can go to the next slide. So if we see the current critical care capacity and the healthcare worker shortage, you can see that this was a survey done by one of my mentors, Dr. Anwar, and one of my colleague, Dr. Naveedur Rahman, in 2010, and was published in 2014. And this, you can see that there are few dots of ICU capacity and intensivist in Sindh, and then scattered in somewhere in Punjab and then in KPK. So they could only find only 16 PICUs in Pakistan, and where they had a one bed per 500,000 children. So that means that there is a huge need for development of pediatric ICU. And if you see this survey of healthcare worker shortages, so we are in moderate healthcare worker shortage category, and this has been issued by the WHO. So that means that we are in critical shortage of nurses, technicians, as well as physicians. And you cannot imagine an ICU without the nurses, because nurses are the backbone of critical care. So this is the current situation in which we are living. And if we move on, so we will see that there is so you can see that in the developed world, an ICU looks like a very intensive environment. So you can see that there is a small child in just in the middle, and then there is a whole lot of machinery and technology all around that patient. So ICU is a very resource intensive environment. And if you can show the next thing, so you will see that in Pakistan we are struggling, as I mentioned in the last slide, with, you can see that the families have to provide oxygen to their kids, because we don't have enough oxygen supplies, we don't have enough ventilators, and we don't have enough human resource to provide care to all these patients who get onto the ventilator. And if we, as I mentioned in my last slides, that congenital heart disease is one of the major determinants of our morbidity. And Pakistan, along with India, China, and Indonesia, are one of the largest contributors of congenital heart disease all over the world. So if we talk about the challenges, the challenge is that the ICU is and in fact the congenital heart disease is a resource intensive service. It requires a lot of investment in infrastructure building. It requires a lot of investment in human resource. And the problem is that once we train our human resource, they go to outside abroad for better prospect. So ICU care is a demanding care, and it leads to burnout and moral demoralization and stress. And then people opt out of these intensive environment to do jobs which are not that stressful. And then along with all these challenges, we have patients who are very malnourished, who presents with a different physiology because of malnutrition. They present late to the healthcare facilities, and that again complicates the problem. And they once they present, we don't have the enough healthcare worker provision to take care of all these patients who have already got complex because of the nature of their disease and malnutrition and multitude of infections. So what solution we can have among all these challenges? Because in the end, we have to find certain solutions to provide care and optimal care to these children. And if we talk about the solution, next slide. So the solution involved, the first thing is that capacity building. So how do we do capacity building? So remember that to train a surgeon, to train a cardiologist, or to train an intensivist, it takes 5 to 6 years and sometime more to get a trained intensivist in the unit. So how do we then do some innovations uh, to overcome all those? So one is using technology and building contextual training program. So there are few very good online resources where nurses, physicians, technicians who are providing care to the critical care patients can go on, like Open Pediatrics, like Pediatric Fundamental of Critical Care sport, like Pediatric Intensive Care course. So our team has been blessed with some of the good mentors, and we have done some of these courses on pediatric mechanical ventilation and teaching the basic pediatric intensive care course to people who provide care at the bedside, and the response and the take has been really excellent. And then we have just started the pediatric critical care fellowship, I think, and we are very hopeful that this will bridge this gap of supply and demand. And then we also need to work on the developing a nursing specialty and increasing their role to provide this care and to bridge this gap of supply and demand. And I strongly believe, and I am a strong advocate of developing these skilled human resource at the local level. We cannot rely on people from outside the country coming and doing missions or doing our help. Yes, we can collaborate with them and we should collaborate with them, but it is the local solution which will solve our local problems. So the second thing coming on to the solution is the improvement in clinical services. So how we can improve the clinical services? So first thing is that we should do things or interventions which are low cost and high yield, like triage, so early pickup of these congenital heart disease patients, developing checklists in the operating room, in the ICUs. And these checklists lists are very important and as well as very easy to be done, and they have been shown to even reduce the mortality and outcomes in the critical care environment. Then developing protocols and standard ordered sets can really help people who are less trained, who have less experienced of the critical care of managing these complex patients. These protocols can be really helpful. And another thing which is a kind of a new emerging theme or phenomena is task shifting or task sharing. So what it means is that you take a high level of work or job done by a person who is not trained, by leveraging the technology. So today is a world of technology, and using artificial intelligence, we can increase the capacity of our health worker who are less trained or less experienced, because these decision support tools can really help predict our patient's trajectory, and I'll show you an example later on. And then we leverage technology to contain the cost, like development of oxygen concentrator, use of high flow nasal cannula to decrease the ventilation need, using closed loop ventilation so that the ventilator detects the patient's mechanics and keeps on providing ventilation without any human intervention. And then there are variables for monitoring from a distance or telemonitoring, then point of care testing and decision support tools. So these are all things which are very high yield, and these can be the local solution. And then as I talked about innovation and leveraging technology, so this is just a screenshot from a de-identified patient's data that shows the heart rate, SpO2, and the hemodynamics. And you can see this red and green bar. This is called that this patient, this red means that this patient is not getting enough oxygen supply to the tissues, which is the index of oxygen delivery. So that means that we need to do certain intervention to improve the hemodynamics. And as you can see that there were certain changes in the hemodynamics. As soon as those changes improved, the patient became stable. So you can just by looking at the color and the bar of red and green, one of the nurses who are just new from the nursing school can pick up this deteriorating patient, call the physicians at the bedside, and detect the deterioration, because this is one of the major determinants of outcome in the ICU, and that is that you pick these patients early on during the course of deterioration, and then you do an early intervention to prevent those deterioration. So the next thing is building a contextual research programs. So these are very much needed because we don't have our local data. So to estimate the actual need and the burden, and these estimate will help us to advocate our cases, to advocate the need for these children, and for also for the resource allocation from different funding bodies, including government. And collaboration is very important, national and international. And I'll discuss these quality registries and their role in detail in next couple of slides. And then research is also needed to develop local evidence-based medicine programs, and then standardized case or protocolized case. This will help us to reduce the cost and also to contain the cost. And then we can also do certain proof of concept studies for the use of technology in very low resource setting. So talking about the quality, so quality remains central to any congenital cardiac disease program, and this comprises of three major factors, and that is the structure, that what is the facility, what technology are there, what resources and equipment are there in the in that facility, then process, and then outcomes. So all these three measures should be measured in any good congenital cardiac program, and these three are the main pillars of a quality program in any congenital heart disease program. And I'll just show you a couple of examples from what has been published from Pakistan at the Afan University, as well as from the US. So my next slide shows that just by contributing our data and sharing our data with the registry called International Quality Improvement Collaborative, you can see that our infection rate fell significantly. And you can also see that our mortality also decreased as we started, because we started contributing, we started learning from all those centers which were contributing in this registry. And we also learned certain things, and certain other centers learned from our things. It's all that how do we do different things, and what our experiences are, and how, and we can get we can learn from their experience, and what people can learn from other experience. And my next slide shows the more or less a similar data from the US, that one dozen of their children hospital cardiac programs contributed data, learned from each other, received input from the registry, and you can see that their mortality and their rate of mortality started decreasing, and it almost went to less than 2%, which is huge improvement, coming from 3 to 4%. And you can see that there wasn't any variation, significant variation between the centers. And there was also a reduction in the length of hospital stay, in the ventilator associated pneumonia, and as well as in other adverse event that can happen in an ICU setting. So these databases and registries are very of utmost importance for the success of a congenital cardiac program, as well as for the success of care, care provision in the pediatric ICU. So and if then I'll just take couple of more minutes to discuss parental law role and how we can be more we can be more collaborative with the families. So remember that this time of children in the ICU is the most distressing time for these patients, and ICU experience, as I said already, has a long term impact. It has a short term impact, but it also has a long term impact. And if we collaborate, we involve parents in the care processes, that is always a win win situation. So what we demand from the parents is that trust the caring team, but demand and ask and question your concerns directly with the team who is taking care of these patients. Strictly ask the staff to follow infection control, because infections are one of the major determinants of outcome after a congenital heart disease surgery. And I think we as physicians and healthcare providers and healthcare administrator should focus on an open door policy for the parents, that we should not put any restrictions on the parents when they want to visit their babies, because this has been proven to be one of the very good intervention for the child, as well as the overall outcome and their satisfaction. And I always encourage parents to stay with the child and start interacting irrespective of the age, start touching their child as soon as the parents get off from the ventilatory support and the child is awake. And then the next step could be the formation of parent sports group to support them during this distressing time. And because this is one of the major distressing time, finding positivity in all those circumstances is what, if parents can find those positivity, then they can be a great collaborator and great partner in the care of their child in the ICU. And I'll end by just showing you one example that which we applied around 6 years back, and that was called the Family Centered Round in Pakistan, PICU. So this was again done by one of our nurse lead, and you can see that the parents feeling of inclusion in their child care, as well as their feeling of inclusion in the decision making, increased significantly after they were involved in actively during the rounds and decisions, and their interaction with the physician team, as well as their satisfaction became significantly improved after that. So with this I will end, and I look forward to PCHF as one of the leading congenital cardiac program, and developing the all things which I have discussed, and leading as a major solution provider for this congenital cardiac disease patients. Thank you.
Thank you very much, Dr. Abbas. बहुत ही impressive और amazing presentation थी, क्योंकि in my time with PCHF or in my rotations in Pakistan in pediatric cardiology or intensive care units, अभी तक I haven't actually seen such examples, significant examples of the use of technology and integration into management, intensive care management of patients. Particularly मुझे वो task shifting वाला जो आपने एक option present किया, I think that is very
Yeah.
interesting and something that PCHF will definitely be looking into the future. So, sir, moving on to the questions and answers, आपने बहुत सारे advantages बताए हैं of the use of technology in adapting intensive care, pediatric intensive care in Pakistan. तो कुछ हमें drawbacks भी बता दीजिए, या कुछ challenges जो हैं when it comes to the technology and innovation application in the LMIC countries like Pakistan.
Yeah, so I think challenges, I would touch the challenges first, and challenges are training, getting that data set us to train what algorithm we are using and what artificial intelligence solution we are bringing, and making it very contextual to the local population कि वो local population पे applicable है या नहीं है. So what we did, जो मैंने आपको example दिखाई थी, so we got this commercial solution from the US, but the first thing we did is that we analyzed its performance on our patient, and guess what, that its performance was even better. Though हमारे जो patients थे, it was tested initially on very young patients like neonates, but it performed very well even on our patients who had an age of 10 years or 12 years. So and this is one of their inherent thing कि जब ये artificial intelligence के जो आपके algorithms होते हैं, the more data you give them, the more their performance gets better and better with the passage of time. So I think drawbacks ही हैं कि if you start using them without contextualizing or testing on the local population, then that is I think it can lead to a loss. And another important challenge is investing in the solution. And I think that personally, I think that Pakistan has the capacity to develop all these things. We just need to have a good collaboration with physician, software engineers, other engineers, and then collaborate with them. This is one of the major thing which is lacking in Pakistan, and this happens in any university all over the world, that people collaborate with outside their field. Like I am a physician, I usually don't like, I'm not comfortable collaborating with the engineer, etc. So this is where we need to collaborate and overcome this challenge, that we can give their input, they can give their input, and then we bring a good solution on. So this is another challenge, that collaborations and investing in all these solution. And then another challenge, our potential barrier is this ethical application of ethical or patient data privacy. So I think there should be very strict barriers so that no patient privacy data or patient health related data is transferred anywhere where this is not supposed to be.
ठीक है, thank you, sir. So, moving forward, so what would you suggest for hospitals who want to improve their processes? Will it be better अगर hospitals जो हैं वो बाहर से ये technology source करें, या फिर ये कि इसकी local production पे emphasis या focus किया जाए?
I think local. I think without any doubt, we have examples of developing these solution, and I think this is what we need. That we have. I mean, we have the human capacity to develop this, and we can get funding from different donors or even research agencies for this. And this will be a contextual research leading into implementation. And I would also like to add another thing, that व्हेन आप जब आप ये इस तरह की टेक्नोलॉजी लेके आते हैं और अगर आप उसको अप्लाई करते हैं विदाउट बिल्डिंग अ फ्रेमवर्क ऑफ इम्प्लीमेंटेशन कि आप इसको कौन क्या करेगा, विदाउट डिफाइनिंग द रोल्स एंड रिस्पॉन्सिबिलिटीज, देन इट्स अ वेस्ट डाउन द ड्रेन. ठीक है, सो आपको what we did is that when we implemented this, we trained everybody who was involved in the patient care in our ICU. We made certain triggers and responsibilities, एंड कि ये इस फॉर एग्जांपल कि अगर नर्स एक बार को रेड होता देख रही है तो व्हाट शी इज सपोज टू डू, किस टाइम पे उसने किसको कॉल करनी है. वी एम्पावर्ड देम टू कॉल द अटेंडिंग फिजिशियन at whatever time in the day or night कि ये इसका रेड हो रहा है. And we also decided to make certain decisions of patient care based on those data. So अगर आप ये सारा framework of implementation नहीं बनाएं कि इसको हम utilize कैसे करेंगे या practicality में कैसे लेके आएंगे, then it becomes very tough. So this is also important that the whole team is on the same page, and then you go and implement it.
तो सर अराउंड कितना टाइम, कितने ड्यूरेशन लग जाती है इन मतलब आप लोगों को आगा खान यूनिवर्सिटी में कितना टाइम लगा था इसको फुली इम्प्लीमेंट करने में?
So good question. So once we implemented it, so from the day zero when we implemented and the system went live, it took almost around 4 months for everybody to get on the same page. So we trained our cardiologists, we trained our surgeons, we trained we self our intensivists, our nurses, our residents, our fellows. So everybody was like on the same page. So it took some time, and then different people have different question because this is a new thing. So हर कोई पूछता है कि so what I'll get from this. So what another utility is that we can use this model as a remote monitoring. If I am sitting at home at night and one of my patients gets sick, so somebody can call me and I can review the patient's data sitting at the home and instruct them कि अब क्या करना है, या to decide कि whether I need to be on the patient's bedside to do certain interventions.
जी सर, तो थैंक यू फॉर दैट। तो नेक्स्ट क्वेश्चन हमारा ये आया कि आपने एक एग्जांपल दी थी यूजिंग आर्टिफिशियल इंटेलिजेंस टू मॉनिटर ऑक्सीजन सैचुरेशन। तो कुछ इस तरह मतलब इस तरह टेक्नोलॉजी है जो यूज करते हैं टू कंट्रोल या मैनेज post-surgical infections, for example, subacute bacterial endocarditis prophylaxis, yeah, any other infections?
Yes, so I think these technologies are developing. I mean, they have the capacity to answer whatever question you are asking. So, for example, there are algorithms जो आपको पहले से predict कर देंगे कि इस patients को अभी pneumonia होने लगा है in the ICU. They can predict कि इस patient को अभी bed ulcer के risk पे चला गया है ये patient. So you better do certain things to avoid कि इसको bed sores नहीं हो. सो एब्सोल्युटली ये जो इन्फेक्टिव एंडोकार्डाइटिस है इसको भी प्रिडिक्ट कर सकता है. इट्स इम्पॉर्टेंट कि यू आस्क सर्टेन क्वेश्चन एंड देन यू फीड दैट डाटा टू ट्रेन योर एल्गोरिदम. So I think yeah, all of these questions can be answered, but you have to train the algorithm first and then test it and then apply it. So everything is not available commercially, but yes, they have the capacity to answer any question which you want to answer.
That is actually very impressive.
Yeah.
So, sir, moving on to the second part of your presentation on the involvement of parents in post-operative ICU care. अगर contextual point of view से देखते हैं, तो culturally, because generally, unfortunately, there is less knowledge about patient care in our population. तो इसके hazards कुछ हमें बता सकते हैं? Advantages तो आपने बताया कि it does improve outcomes, लेकिन कुछ hazards के हवाले से भी कि what should parents be careful of when they are allowed to approach their families, their children in ICUs?
Yes, so you will remember कि जो पहला point उसमें मैंने डाला था that was trusting the caring team. If the family will not trust the caring team, then it will become very tough situation. You know कि family is sitting at the bedside और आप patient की suction कर रहे हैं या the kids start crying, so they have emotion attached to that child and they may react badly. So I think this is a thing which comes with a cultural build-up, and it takes some time to evolve from one state to another. So इसीलिए मैंने नीचे जो suggestion में one point जो लिखा mention किया था, that was parent sports group, that we can make certain volunteer parent sports group who can just come and who ऐसे लोग जिनका previously उनका कोई बच्चा आईसीयू में या हॉस्पिटल में रहा है, सो दे हैव अ बेटर एक्सपीरियंस कि किन किन फेजेस से ये पेशेंट्स गुजरते हैं, बिकॉज ये जो सीएचडी की पॉपुलेशन होती है स्पेसिफिकली, दे हैव अ वेरी सिमिलर एक्सपीरियंस कि ये आते हैं, इनका इको होगा, किसी की कैथेटराइजेशन होगी, एनजीओ होगी, एनजीओ में कुछ प्रोसीजर होंगे, सर्जरी होगी, फिर वेंटिलेटर पे जाएंगे, फिर वेंटिलेटर से ऑफ होंगे, फीडिंग स्टार्ट होगी, ड्रेसिंग एटसेट्रा, चेस्ट ड्रेन्स वगैरह होती हैं. So these parent sports group can really help those. But yes, I won't say that one should always start with के open door कर दें and give everyone. So you have to have people who can control the traffic, teach parents कि उन्होंने hand washing कैसे करनी है before and after touching their baby, उन्होंने किस तरह से find that positivity in all that stressful environment, ताकि वो एक दूसरे को भी support कर सकें. And we have seen that sometime when all the patients in the ICU are sick, so what happens is that they feed negativity one into another, and that is sometimes very disastrous. So in that cases parent sports group और ये वाले लोग बहुत help करते हैं जो लोगों को encourage करते हैं कि yes, this is a tough time, this is a very testing time family के लिए, but we will come out of this and your kid will come out of this, and जो team care कर रही है, they are doing their 100% to get this baby out of the ICU and out of the hospital in the best way possible. But I think what this comes with time and in phases.
Definitely anything मतलब उसकी जो application है 100% उसके जो outcome improvement होता है उसमें time तो होता है, but
Yes.
it is very promising to see such positive directives in CHD care in Pakistan. So sir, before we conclude, there is just one last question from actually a parent कि what are the warning signs for parents जिनके बच्चे की surgery हो चुकी है और जो घर आ चुके हैं कि हम दोबारा that we seek medical attention again.
Yeah, so I think very good question. So ये जो CHD के patients होते हैं, once, so if आप अगर इनके parents को, before coming on to that question, I'll just add कि अगर आप parents को care में involve करेंगे in the hospital, so आपके जो बच्चे हैं वो जल्दी ICU से और hospital से discharge होंगे, so that will lead to decreased length of stay and you can provide more care to more number of patients. And number two, they will be better able to handle their kids at home because इनकी ड्रेसिंग्स होती हैं, बात देना, मेडिसिन कुछ होती हैं जो अपने टाइम पे देनी होती हैं. सो कमिंग ऑन टू दिस स्पेसिफिक क्वेश्चन, सो डेंजर साइन यूजुअली ये होते हैं कि अगर बच्चे का जो रंग है वो नीला पड़ रहा है, नंबर वन. सेकंड, अगर बच्चे को बुखार हो रहा है आफ्टर द सर्जरी. नंबर थ्री, अगर इनकी जो वो जख्म है जहाँ पे सर्जरी हुई है, अगर उससे पानी आ रहा है या पस आ रही है, ये वाली चीज़. नंबर फोर, अगर पेरेंट्स को ये फीलिंग भी है कि ये बच्चा जो है आज रूटीन के मुताबिक नहीं चल रहा, सुस्त है, ज़्यादा सो रहा है, खाना पीना नहीं खा रहा है, या उसको बहुत ज़्यादा पसीना आ रहा है, तो ये तीन चार ऐसी अलामात होती हैं जिसमें हम कहते हैं कि कम बैक टू द हॉस्पिटल और कम बैक टू द इमरजेंसी to or visit your physician as soon as possible.
ठीक है, thank you very much, sir. Before we conclude today's session, I would like to thank all our panelists, all our attendees, all our viewers, parents, everyone जिन्होंने tune in किया. तो sir, before we conclude, आपकी तरफ से कुछ ending remarks, especially उन young professionals के लिए जो आपकी तरह इस field में आगे बढ़ना चाह रहे हैं और excel करना चाह रहे हैं.
So I would say that pediatric critical care and especially pediatric cardiac critical care is one of the most demanding and challenging field, but this is one of the field which is needed very much in Pakistan. And if one of the listeners who is interested in pursuing this, please get in touch with us, with people who are doing critical care. We will be more than happy to facilitate. And and secondly, because this is a PCHF platform, so I so look forward that PCHF is the torch bearer of CHD care and especially this ICU care in Pakistan. And thank you very much for providing me this forum to talk on this.
Thank you very much, sir. In fact, we are honored, PCHF is honored, that it is a collaborative effort against the fight against congenital heart diseases in Pakistan. So thank you to everyone once again, especially you, sir. So take care and Allah Hafiz.
Thank you, Allah Hafiz.